The views and opinions expressed on My Story Living with Lupus podcast represents each person's individual experience. By listening to this podcast or reading our blog, you agree not to use this podcast or blog as medical advice to treat any medical condition in either yourself or others. As always, consult your own physician for any medical issues that you may be having. My Story Living with Lupus podcast is officially trademarked, all rights reserved. Thank you for joining me for another episode of My Story Living with Lupus podcast. I'm your host, Susan Hendricks, and I'm so glad that you can join me on this Friday, February the 4th, 2022. Got a question for you. Do you know what seasonal affective disorder is? What about the most common neuropsychiatric disorder people with lupus have? Well, that's what we're going to be talking about today, along with the latest in healthcare news. So, you know what I want you to do. All the way from the United States to Nara, Japan. Get ready to grab your cup of coffee, your cup of tea, and to my listeners late at night, you know I appreciate you. So, go grab your favorite glass of wine and come on and join the conversation right here on My Story Living with Lupus podcast. And I'm back. I'm going to start off talking about SAD. SAD is seasonal affective disorder, seasonal depression, seasonal mood disorder. You know, we may hear a lot during the wintertime of people talking about how their mood changes and how some people can become depressed during this time of the year. Well, seasonal affective disorder, SAD for short, is a type of depression that comes and goes with the seasons. It usually starts in the late fall and early winter and goes away during the spring and summer. Some people do have episodes of depression that start in the spring or summer, but that is a lot less common. And do you really think it's because some of us are stuck in the house and we can't go out normally like we do in the spring and summer, and we're not getting that vitamin D, the sun hitting our skin, the sunshine, and I believe this, the sunshine makes us feel better, happier, joyous. Well, the symptoms of SAD include sadness, gloomy outlook, feeling hopeless, worthless, and irritable, loss of interest or pleasure in activities you used to enjoy, low energy, difficulty sleeping or oversleeping, carbohydrate cravings and weight gain, thoughts of death or suicide. SAD is more common in women, young people, and those who live far from the equator. You are also more likely to have SAD if you or your family members have depression. The exact causes of SAD are unknown. Researchers have found that people with SAD may have an imbalance of serotonin, a brain chemical that affects your mood. Their bodies also make too much melatonin, a hormone that regulates sleep, and not enough vitamin D. The main treatment for SAD is light therapy. The idea behind light therapy is to replace the sunshine that you miss during the fall and winter months. You sit in front of a light box every morning to get daily exposure to bright, artificial light. But some people with SAD do not respond to light therapy alone. Antidepressants and talk therapy can reduce SAD symptoms, either alone or combined with light therapy. So, if you have been feeling seasonal affective disorder, talk to your doctor about it so they can help you figure out what is best. Well, I should say, what plan of treatment is best for you. Stick with me. I'll be right back. We know that February is Black History Month. So here's a little history for you. Before there was Hillary Clinton, there was Shirley Chisholm. That's right, Shirley Chisholm began exploring her candidacy in July 1971 and formally announced her presidential bid on January 25th, 1972, in a Baptist church in her district in Brooklyn. There she called for a bloodless revolution at the forthcoming Democratic National Convention. Chisholm became the first African American to run for a major party's nomination for president of the United States in the 1972 U.S. presidential election, making her also the first woman ever to run for the Democratic Party's presidential nomination. And I'm back again. And now I'm going to talk about the most common neuropsychiatric disorder people with lupus have. Now, the American College of Rheumatology defines 19 neuropsychiatric syndromes In systemic lupus erythematosus, better known as SLE, the most common neuropsychiatric disorder people with SLE have is headaches. That's right. Although the existence of a specific lupus headache and the optimum approach to headaches in SLE cases remains controversial. Now, for those of you who are just joining, we know that lupus most often harms the heart, the joints, skin, lungs, blood vessels, liver, kidneys, and nervous systems. The course of the disease is unpredictable, with periods of illness called flares alternating with remissions. The disease occurs 9 times more often in women than in men, especially between the ages of 15 and 50, and is more common in those of non-European descent. SLE is treatable through addressing its symptoms, mainly with corticosteroids and immunosuppressants. There is currently no cure. SLE can be fatal, although with recent medical advances, fatalities are becoming increasingly rare. I disagree with this. That fatalities are becoming increasingly rare. If you are on social media, you always hear about someone with lupus passing. So I do not agree with that at all. Survival for people with SLE in the United States, Canada, and Europe is approximately 95% at 5 years, 90% at 10 years, and 78% at 20 years. And you know what? I disagree with that also because no one knows the time or hour of your demise but God. So I'm going to leave that one alone. We know that lupus is one of several diseases known as the great imitator. Okay, because it often mimics or is mistaken for other illnesses. This is why it's so hard for us to get diagnosed quickly with lupus because physicians have to run a whole gamut and rule out different illnesses before it comes to a definitive diagnosis of lupus. We know that dermatological manifestations can occur with lupus. We also know hematological manifestations can occur, cardiac manifestations can occur, pulmonary manifestations can occur, renal involvement can occur. Now, when it comes to neuropsychiatric manifestations, neuropsychiatric syndromes can result when SLE affects the central or peripheral nervous systems. The American College of Rheumatology defines 19 neuropsychiatric syndromes in systemic lupus erythematosus. The most common neuropsychiatric disorder people with lupus SLE have is headaches. Now, I'm going to go on before we go into the headaches. Although the existence of a specific lupus headache and the optimal approach to headaches in SLE cases remain controversial. Other common neuropsychiatric manifestations of SLE include cognitive dysfunction, mood disorder, cerebrovascular disease, seizures, polyneuropathy, anxiety disorders, and psychosis. It can rarely present with intracranial hypertension syndrome, characterized by elevated intracranial pressure and headache with occasional nerve paresis. So let's talk about the headaches. Headache is a symptom of pain in the face, head, or neck. It can occur as a migraine, tension type headache, or cluster headaches. There is an increased risk of depression in those with severe headaches. Headaches can occur as a result of many conditions. There are a number of different classification systems of headaches. The most well recognized is that of the International Headache Society, which classifies it into more than 150 types of primary and secondary headaches. Causes of headaches may include dehydration, fatigue, sleep deprivation, stress, the effects of medication, and recreational drugs, including withdrawal, viral infections, loud noises, common colds, head injury, rapid ingestion of a very cold food or beverage. I think we call those brain freezes, and dental or sinus issues. Treatment of headaches depends on the underlying cause, but commonly involves pain medications. A headache is one of the most commonly experienced of all physical discomforts, and half of adults have a headache in a given year. Tension headaches are most common, affecting about 1.6 billion people. That's 21.8% of the population, followed by migraine headaches, which affect about 848 million individuals. Now, I used to get very bad, severe migraines, and it would be to the point that I felt like my head was just going to explode. Um, I could not open my eyes. My eyes had to stay closed. I did not want the TV on because it seemed that the noise of the TV would amplify my headache. My headaches got so bad that I would just grab my head and curl up into the fetal position, and I would just be rocking back and forth. That's how bad my headaches would get, and the nausea would set in. And oh my God, when it would ease up, it felt like a ton of pressure had been lifted off of me. That's how bad it would get. I would cry. And I don't know if you guys have experienced a migraine of that um, intensity where you would just, it would be nothing that I could do. I tell you, I do not wish that type of headache on my worst enemy. I would just have to let it subside. They did not, the doctors, when I say they did not know what was going on with me, but the headaches, the migraines, oh, I feel like my brain and my head was just going to just explode. That's how bad they would get. And if you were to walk across the floor, and it was carpeted in my bedroom, and I would hear my daughter walk across the carpet, and that would just trigger it. And oh my gosh, I don't wish that on my own worst enemy. So that is the most common neuropsychiatric disorder individuals with lupus have, are the headaches. And I tell you what, I thank God that I have not had a headache like I just described in a long time. So, stay with me and I'll be right back. Don't go anywhere. We're back and we're discussing African American women with lupus at higher risk for adverse perinatal outcomes. African American women with systemic lupus erythematosus were found to be at increased risk for preterm and small for gestational age births, even prior to clinical diagnosis, according to data published in Arthritis Care and Research. Despite the interest in pregnancy among women with SLE, important gaps in the literature remain. Per Megan Angley, PhD, MPH, of the Department of Epidemiology in the Rawlings School of Public Health at Emory University, and colleagues wrote, there is limited research on preterm birth and small for gestational age, better known as SGA, specifically among African American women with SLE, and only one study has examined perinatal outcomes before SLE diagnosis among African American women. They also asserted in the present analysis, they examined the risk of preterm and small for gestational age birth among African American women with SLE compared to the general population of African American in a large women in a large metropolitan area. Angley and colleagues analyzed 586 births to African American women with SLE identified from the Georgia Lupus Registry and the Georgians organized against lupus cohort. Participants were linked with birth certificates by the Georgia Department of Public Health and comparison birth certificates to African American women in the same geographic region were obtained from the National Center for Health Statistics. Births were designated into 4 categories: occurring more than 3 years before SLE diagnosis, 0 to 3 years before SLE diagnosis, 0 to 3 years after SLE diagnosis, or more than 3 years after SLE diagnosis. Long risk models were used to compare the risk of preterm birth, or SGA, among SLE births and each diagnosis timing category to the general population, adjusting for maternal age, education, and parity. Overall, 28.5% of births in their cohort of African American women with SLE were preterm compared to 15.5% among African American women in the general population. Angley and colleagues wrote. Further went on to state that researchers found that births to women with SLE were most likely to occur preterm, 3 or more years after diagnosis, followed by 0 to 3 years after SLE diagnosis, and 0 to 3 years before SLE diagnosis. However, this was not observed in the 3 or more years before SLE diagnosis group compared with the general population. Though similar results were recorded for SGA, the researchers noted that patterns were different. The risk of SGA births were 10.9%, more than 3 years before diagnosis, but 27.9% within 3 years after diagnosis. The researchers added by more than 3 years after SLE diagnosis, the proportion of births that were SGA was 21.3% of births. More work remains to be done to characterize the additional risks around pregnancy and childbirth that African American women with SLE face. Healthcare providers, especially those in communities of color, should be better educated about SLE and have a lower threshold to suspect SLE in the peripartum period. Now, this does not exclude other providers. My feeling is that all providers need to be more educated about SLE, period. Well, it's that time for me to go. But before I go, I want to leave you with this. Don't waste your time looking back on what you've lost. Move on. For life is not meant to be traveled backwards. The only time you should ever look back is to see how far you've come. I'm your host, Susan Hendricks, for my story, Living with Lupus podcast. Have a peaceful, joyous, and oh so blessed weekend. You guys stay safe, and I'll see you next week for another episode.